thank you for inviting me to come and talk on this topic today. I am a data lover. I love statistics. I enjoyed maths at school. So some of you will be thinking I'm a little bit weird because of that. And I know that some of you might be thinking this is a topic that you're not interested in, or you think data is a bit of a swear word or a very scary word. So I'm hoping that if I start showing my screen while I'm talking, I'm hoping that maybe I can help you fall in love with data a little bit after this session, as much as I enjoy it. Is that okay? Can everybody see that? Yeah.
Yep, that's fine.
Yes,
Heidi.
that's absolutely fine.
Cool,
Yeah.
real. So yeah, thanks, Sarah. My name is Heidi Sandoz. I am now mostly an independent tissue viability consultant. I work 1 day a week now as a tissue viability nurse in Hertfordshire Community NHS Trust. I'm no longer the lead there. I've also got an associate position with the National Wound Care Strategy Programme, supporting the pressure ulcer surveillance work, and I am the Skincare Champion Educator, funded by the Society of Tissue Viability as well. What I'm aiming for today is that we can have a little explore about why data is important. And it is absolutely important that we are capturing data, not just about pressure ulcers, but about lots of other things. I want to have a look at some of the different ways to present that data, particularly for some of you, and I don't know where you're all working. I don't know if you're NHS, if you're in social care or care home settings, but sometimes we get asked to look at data that is presented in a very poor way. And I want to be able to give you some techniques to turn that around if that happens to you. And we'll consider how we can use data to identify the needs where we need to make some changes, how we can use it to measure progress, and also to measure the effectiveness of quality improvement. And then I will talk a little bit about our aims for the national pressure ulcer surveillance work in NHS England, that will be. What is data, apart from this scary word? Well, it's actually a Latin word, and the individual value for that is datum. So it's actually a collection, really. It's a body of facts. These can be individual facts, can be masses of statistics, individual items of information. Various definitions there from Wikipedia and dictionaries. But it can also be our individual personal information, and we hear a lot nowadays about data protection. That can be something as simple as our name. It can be something like our date of birth, our address. It can also be our medical history. So there's lots and lots of ways that we can look at data. But what we're talking about today is counting pressure ulcers, really. That's what today is about. So that's what our focus is. And my next picture is piano keys. Now, I am an Elton John fan, but this isn't why I've got piano keys here. The reason why I've put piano keys here is because these are keys that go up and down. And when you're given data in this format, that's essentially what is happening here. This chart is over a year. It's telling us the number of pressure ulcers by category that were acquired in a community organisation over the period of that year. And what you can see is lots of coloured lines going up and down. I don't know if you can see my cursor, but let's focus on the blue lines. These are the category 2s. And let's have a look at a month where it seems quite low. So here we are in May. But actually 2 months later, it's nearly double that. And then it comes back down again. And then it goes up again and down again and up and down as it goes. And if you look at the purple ones, which often is where our senior managers want to look, because these are the category 4s, you can see they're doing exactly the same. We've got some months where we've got no category 4s and some months where we've got 5. But it goes up and down as the month goes on. So it's not really telling us whether we're any better or any worse over a period of time. So they're very nice to look at, very pretty, very easy to do on an Excel spreadsheet, but they don't really tell us what we want to know. Have a think about your journey to work. Those of you that drive to work or go on a bicycle or even on the trains, you will have days when that journey runs very smoothly and you can actually get to work, say, in 20 minutes, half an hour, depending on how far away you live from work. But on other days, you may get stuck in a traffic jam and it might take twice or 3 times as long to get to work. I live near the M25. We have a problem on there. It can cause problems in all the peripheral roads around it. And my journey to work can be really upset by something like that. But what these are over time, over the year, are journeys that are sitting within normal variation. So this is a normal variation curve, if you like, normal distribution curve. And the section in the middle there with the blue stripy lines, this is telling us that most of the time our journey will fit within this period. So we can have times when we get to work really quickly and times when it takes much, much longer to get to work. But over a long period of time, most of the time, they're all normal variation. And whilst we might feel grumpier about the days that take longer, actually, we probably have just as many days that we get there really quickly. When you go to the ends of the two curves, you'll have some extremes, days when you might get there really super quick and days that just take way, way too long, and you may even abandon the journey and just come home. And those are the extremes of that normal curve. And that's really what these charts are showing us. They are just everything's within a normal variation, we think. So it's not really helping us understand whether we've got consistent extremes at one end or the other. Even worse is when you're presented with data like this, in a table like this with just numbers, and you get one of these every month telling you what's going on. And if you've got somebody at your ICB board or at your own trust board who's looking at this, they'll just look at the bottom numbers there in the total and then look at last month's and go, we've had 17 more pressure ulcers this month than last. Why is that and what's going on? So that's happened to me on many occasions over the years as a TVN lead. And what I do when that happens to me is I turn up at the board meeting that I've been requested to present at, and I will give them what I call an SPC chart. So these are statistical process control charts, not something I've made up. But when I first discovered these about 10 years ago, I thought they were magical because they really can show people that actually what we've just been looking at in that bar chart, those piano keys, is actually quite normal. You can access these through the Making Data Count site, and I'm going to give you a QR code for that in a minute so you can go straight to that. They're all set up. You can put your data in and it will churn out one of these charts for you. What's nice about these is that they are over a period of time, and you can see when everything's grey as a dot there, that's within normal range. Everything's sitting around the mean in the middle and within your upper and lower what are called process limits. You may get periods of time where the dots are orange. Now, in pressure ulcers, orange is bad because it means something's going up, and blue is good because it means something's going down. And this is a really good way of showing that actually, yes, we have got a problem. We can now see that we've got more pressure ulcers than we normally have because it's flagging as orange. And then we decided to do something about it. This is a fictitious example. We've introduced a skin bundle in our local area, and what we started to see thereafter was the number of pressure ulcers consistently came down and our dots went blue. Over a period of time, again, if that remains consistent, they will all turn grey again and become our new norm, if that makes sense. So there are a few rules about these charts that you need to understand. And the first is that it's got three lines. You've got the dotted line at the top, the dotted line at the bottom, and you've got the mean line in the middle. So the mean is telling us what the average number is. And most of our dots will be hovering around that line, up and down, up and down. You've got your upper and lower process control limits, and these are set by the data that you've put in there. It's not something you have to worry about, but basically 99% of data will fall within those limits. The tool automatically does it for you. You do need a minimum of 15 data points to create a robust SPC chart. If you're counting pressure ulcers like we do in our organisation, it's usually monthly. But if you're doing it daily or weekly, then you'll need 15 days worth, 15 weeks worth, or 15 months worth. Clearly, if you're doing something by the year, SPC isn't going to be for you because it's going to take a long time to get a chart that you can use. There are some other really useful rules to understand, and kind permission from the improvement analytics team at the NHS for me to use this slide. If you get a single point sitting outside the process limit, top left there, now this is low orange. So this example is theirs. And this could be something like the number of people that have waited more than 2 weeks for, no, let's use a different example. So it's going to be somebody that is low is bad. So you've got the number of people who might have had to wait fewer time to get into an appointment, and higher is good. Does that make sense? So their example is different to what we would do in pressure ulcers. So here you've got a single point outside the process limit. That's just an alert. Oh, is that just a random freak thing that happened this month, or do we need to pay attention to that? You may get 2 or 3 points that are very close to the process limit, and they will flag up as blue or orange. Blue or orange according to whether you're up, whether it's more or less that you're looking for as a good or a bad. If you get a shift of points above the mean, and any shift needs to be 7 points consecutively. So it can be 7 above the mean, as you can see in that bottom left example, or you can get, or 7 below, or you can get a run of 7 that are gradually coming down or gradually going up. So it's actually a way to have your finger on the pulse slightly, that your data can start to tell you that something's changing. That change may be something that's a one-off, we don't have to worry about it, such as the top left, or it's something we might need to worry about, such as the bottom right, or it's showing us that actually something's working and we're doing much better. So much better than the bar charts, what these charts tell you is they tell you a story about what's happening, whether something's happening that's good or bad, whether change is being effective if you've been introducing a quality improvement project, and perhaps you're seeing some improvements from that. So here's a couple of examples. We've got an example on this one here where in October we had absolutely no unstageable pressure ulcers. This is what this chart's telling us about. No unstageable pressure ulcers. Of course, we're not using unstageable anymore with the new recommendations. We would be calling these a category 3. But that was a very freakish event. We had a couple of other times where it was quite low as well, but equally, we've had a few times when it was high. But apart from that one freakish event, all within those normal limits. Now, this one is telling us about caseload numbers for the community nurses. So pay attention to the date here. Look where that is, right at the beginning of the pandemic. So what that clearly told us was something had changed in the number of patients that were coming through our community nursing caseloads. And that change came about because of the number of vaccinations they were having to do, the number of new services that came their way in terms of things like virtual ward, discharge home to assess. We suddenly saw a nearly double number of people on the community nursing caseloads. Fortunately, we didn't see the same impact in numbers on our pressure ulcer caseloads. But that's a story that's useful to think about, because if you're seeing something happening in one place with one piece of data, actually is there something happening somewhere else with another piece of data, and the two are actually, if you match them together, can tell you that something's happening. If we had started to see a big increase in pressure ulcers, we might have been able to think about this and marry the two together. The other thing that can be useful about data is you can actually use it to work out where your bigger problems are. So if you're looking at doing some quality improvement, you know you've got some problems in your data, and you can see that you've got some bigger numbers somewhere. Do you really understand where those real numbers are? So you can use it to look at a focus on a particular area. Is it a particular team, a particular ward that's got a bigger problem than somewhere else that's causing the numbers to go up? Or is it a particular part of the body, for instance, that's affected more than another? And this is where Pareto charts are really, really useful as well. These really help to focus efforts on the problems that offer the greatest potential for improvement, the quick wins, if you like. Pareto's got an 80-20 principle that states that roughly 80% of the effects are going to come from 20% of the causes. And I'll show you what that means in a chart in a moment. You'll be able to see it then. So with Pareto, it allows you to move to target something in particular, because you're going to get a much quicker win if you focus on the bigger problem, where the bigger problem is happening. This chart is just looking at the age of people with a pressure ulcer. There's not really anything we can do about that. But if you look at this chart here, you'll see that we've got percentages up the side here and numbers of people down the side here, and then the ages at the bottom. The chart starts here. The biggest number of people were in this age group here. So that gives us a percentage of a little over 20% here. Cumulatively, this percentage adds up. So we go from 20 to just over 40 to 60 until we get to 80. We can follow that back down, and we can realise that actually the majority of patients that are developing a pressure ulcer are over the age of 75. useful information to know. We can't necessarily do a lot with that, but it might tell us a little bit about the level of care that these people require. It might tell us a little bit about who's looking after these people as well and who's involved in their care. And actually, is there something that we need to be doing there to educate those people around pressure ulcer prevention? So the majority of people were very, very elderly that are developing pressure ulcers. This information can also be presented like this. Now, I don't know about you, but that just gives me a headache looking at that. And I would much rather be looking at that. You don't need to be a whiz to use these tools. You just go to the Making Data Count site. The tools are there. You put your data in and it will churn it out for you. And we've been able to use this in our area when we've thought about pressure ulcers that have been developing in our community hospitals. We've got 3 of those. We don't get many, so it's very small numbers. So sometimes when you're looking at small numbers, SPC doesn't really give you anything. You can see here it's quite tricky when you've got very small numbers. If the difference between 4 and 0, for instance, isn't huge, and we do have some months where there aren't any. We've tried to split them out to work out whether we get more on bottoms or more on feet. And when we put that into a Pareto, it showed us that actually feet and bottoms are the biggest 2 groups that we get. Nobody's going to be surprised about that. But actually, when we look at it again, we can see where 80% is here, so both of them. But actually, if we start focusing on feet, so we're protecting heels, ankles, toes, etc., then that's quite a quick win in a hospital setting because it's quite easy for us to protect feet from pressure. Far more easy to get feet off bed than bottoms off beds and chairs. So actually that's given us a focus. And if we can target these, we can get our numbers down quite substantially. So hopefully some of you are falling in love a little bit with some data. There's way more other ways that you can present data, and the Making Data Count team are excellent at talking about this topic. If you don't get data, if it's hard for you to understand it, it's purely understandable. Most of us are used to looking after people. We're people. We're not numbers people. We like qualitative research. We don't like quantitative research. Understandable. But Sam, who heads up the Making Data Count team, is really, really good at putting this across in a very interesting and understandable way. So if you scan that QR code, it will take you to the NHS Futures website. If you've got an NHS email, you can create an account in there and you can go and have a mooch around. Now, they have upcoming webinars. These webinars last about an hour. There's about 7 or 8 of them in the Making Data Count series, I think. If you can't make any of those, they do have pre-recorded events that you can attend. Of course, if you can go live, you can ask questions. And then the tools that I've shown you, you can find those there and they're very easy to use within there. I wanted to also talk to you about what we're hoping to do nationally and what we're not hoping to do. We are launching, and it is launched, is how we're going to use data nationally now. So you'll all remember, if you're in the NHS, safety thermometer. That was switched off in February of 2020, largely because it didn't comply with the standards of NHS Digital's data requirements. It wasn't anything to do with the pandemic, if any of you wonder why it disappeared then. And what we want to move towards is having a system that everybody can access, that is the same and consistent for everybody. And there's no margin about what will get put in and what won't get put in. And we all know that there were differences in what people were including in safety thermometer, despite the guidance that came out in 2018. Our key driver is that data collection and feedback is taken from point of care, and it's taken from NHS compliant mobile digital technology. Data collection is secondary to operational practice. What do those mean? What they essentially mean is that as clinicians, we are always recording and documenting what we've been doing with our patients, the care that they've received, what we've found, what pressure ulcer they had. We are documenting that and recording it in their clinical care records, be they paper or electronic. Therefore, we should just be able to get the data out of the other side of that. And that's what we're aiming to do. Now, many of you in the NHS will be using your clinical incident reporting data for your pressure ulcer data. And we want that to stop because it's not helpful. It's created an industry of activity for tissue viability nurses in terms of validation and verification of what's been going on in there. And all of that work is happening in the clinical incident reporting system, but not always happening in the patient's clinical records. And actually, the place where we should be getting this right is the clinical records. That means you'll move towards a focus on having a data quality improvement piece of work going on, making sure that what is in the clinical records is accurate so that the data that comes out the other end is accurate. Now, we're talking categorizing, so we always know that we're going to get discrepancies about that. And if any of you want to learn more about this, contact myself or Jackie, and we can come and talk to you about the things that you can do about improving that ability to categorize and how it's recorded in the notes. But bear in mind, you will always need to have a slight margin of error. Just accept that there's going to be times when there's some margins of error around that. Over a period of time, margins of error just become part of that norm, and they're not something that we should worry about too much. So we're aiming for clinical recording accuracy, we're aiming for this data quality improvement, and we will be using national coding sets to get that data so that you as clinicians are freed up to just deliver the care and focus on quality improvement work. You're not running around having to do audits and capture data in other ways. When you're working in acute care, the system that's in place already and has been in place for many, many years is clinical coding. And clinical coders work in the acute care to code clinical records when a patient is discharged. So that period of time that the patient's in hospital from admission to discharge is called a spell. And during that spell, when they've gone home or they've discharged for whatever reason, they will scrutinise the clinical records, looking for clinical diagnosis. And the coding set that they use for that is ICD-10, which is a WHO International Classification of Diseases coding set. And we can see there on the screen that you've got a coding set for pressure ulcers. L89 is the code for a pressure ulcer. So these guys have been doing this for years already. And then we're doing it somewhere else as well. And it's not best use of our time in the NHS, is it? We've got finite resources and we're all extremely busy. You'll see that you've got 4 categories of pressure ulcer that clinical coders can code from. There's no unstageable, there's no deep tissue injury, there's no mention of devices, although there is another code that can be linked to devices. And they've also got a code for unspecified. So if you've written in the clinical records an unstageable pressure ulcer, a coder will code that as unspecified because they've got the words pressure ulcer there, but they haven't got a 1, 2, 3 or a 4 to go with it. If you've written in the clinical records deep tissue injury and not used the words pressure ulcer next to it, the coders won't code it at all because they need the words pressure ulcer there to be able to code it. So this is one of the reasons behind, it's not the only reason by any means, where the categories in the new recommendations, we've narrowed them down to those 4 categories. So we've got that going on. So a patient is admitted, clinicians are documenting the care in the clinical records. The patient is discharged, the records go to the coders scrutinise them against their lists of diagnosis codes and treatment and investigation codes. They put those codes into something called SUS, Secondary Uses Service, and that then feeds into HES, which is Hospital Episode Statistics. And that is really all about how care gets paid for in acute care. So there's certain amounts of money allocated to all of those different codes, whether they're from the ICD-10 or the OCPS-4 codes. In community care, it's slightly different because care is funded in a different way. It tends to be block contracts. And most of us in communities now have got electronic patient records. If you haven't, then there might be something going on around you getting those. We should all really have them now. Most of those records will use either READ or SNOMED codes. And what we have that sits in the background of that as a data set is something called community services data set. There are some mandated fields that community organisations will already be feeding into in community services data sets. So in the community, we don't necessarily have spells because people might stay in our care for many, many years. Clinicians are documenting the care as they go. That clinical and also the non-clinical activity can be automatically coded based on how it's being put into the clinical records. And then analysts can download reports from those records. And then the data from those can get popped up into CSDS. And what we've been trying to understand nationally is, can we see pressure ulcer and leg ulcer information in CSDS? And the answer is yes, we can, but we're not quite in a place to take it out of there and put it into our national portal that we want to use. And that is the model health system. So when Carter did the review a few years ago, the recommendation was that everybody would put their information into model hospital so that you've got consistency about what's being reported and what's being surveilled. And we've all got a place where we can go and look at it all in one place. Everybody's doing the same thing. And you've also got an opportunity to benchmark against other organisations. Now, model health system is an umbrella term that sits over model hospital, model ambulance, model community health, and model mental health. Little caveat in terms of icons, the only two icons that actually exist are the model health and model hospital. I've made the other ones up because they don't have icons yet. So we're really going to focus on model hospital and model community health here, but we will be looking at how we can get pressure ulcers into model mental health at some point as well. If you haven't already signed up to this and you have got an NHS email address and work for an NHS organisation, then that will be your login place to go to do that. And when you're in there, this is only for acute at the moment, that you will be able to see your pressure ulcers. We haven't got pressure ulcers into community health or mental health yet. When you go in, this will be the first page you see. Your organisation will be here. I've blued out this particular organisation's name. And this will be your first page. And it scrolls way down. There's loads of information on this. You might find it quite fascinating to look at. You can see information, for instance, on readmission rates post-surgery. And very often that readmission is about a wound problem. So it's an indication of how many people are having wound problems. And if you go in and look at that by different surgeries, that can be quite interesting as well, particularly as we're focusing on surgical wounds now as well. Where you'll find pressure ulcers is in this quality of care tile. So you'll click on that and that will take you through to the main page. And you can see quite a few things in there about pressure ulcers at the moment. This is an example of an SPC chart in there. And this is what this chart is telling us is the spells with a pressure ulcer diagnosis present as a proportion of all spells. So these are the percentages of people that had a pressure ulcer during their spell, whether it was acquired in care or they came in with it. And you can see this percentage is quite low. This is a large trust with a huge number of beds, actually, this particular one. So this is quite low. So I suspect that actually the information that the coders are getting from the clinical records isn't accurate to go into SUS to come into model hospital. So what that's probably telling you is we need to do a piece of work with what people are documenting in our clinical records and what coders are coding. You can also see the information in a chart like this. This is what's called a variation chart. The black line there is your organisation. And you can see all the organisations that score above the median line are in red and all those below are in green. So you might look at that and think, oh, that's good. We're not too bad. We're right the way down there in the green section there. The grey lines are peers. These are organisations that you might want to benchmark against because they're like you and you can set who they are. But actually, if we look at this organisation here, they're right up here at nearly 3.5%. And if we think about safety thermometer, we knew that with safety thermometer, we were seeing about 5%, 4.6 to 5% of patients at the end of the day were getting pressure ulcers. In the national prevalence audit that was carried out, I think it was near a 7.6%, or maybe even have been 9%. I can't remember off the top of my head now. So actually 3.5%, this organisation's doing really, really well at documenting its pressure ulcers, and coders can record them accurately and it can find its way into the data. So what we need is all these to catch up, because if any of some of these are big organisations, some of them are little, they're like little cancer wards, they're children's hospitals, so you would expect them to be down here. But some of these are huge trusts, and if they are accurate, then we should all be rushing there to see what they're doing really, really well. But what at the moment this will tell you is it's about data quality. The other really useful way you can see this data in here, if I can get my slide to move, is as a trend line. Now in this chart, you are in blue. Black is the national and grey is your peers. What I like about this one is we go back to those piano keys and you get that call that says, your pressure ulcers have gone up this month, what happened? You can actually show nationally some similar trends. I think my cursor might be here. Similar trends. Can you see how the curves are quite often consistently going up at the same time? And I think that's quite useful to be able to show sometimes that actually when we had a bad month, so did everybody else. And when we had a good month, so did everybody else. Who knows what the explanation is about that? The data that you see in here will be 2 or 3 months later. So once your trust and your board get used to it and used to understanding it, if you're getting those knocks on the door, throw an SPC chart at them first and foremost, but then secondly say, but look what's been happening over the year with the trends. We've been very similar to the trends that are national. So that's really useful. I don't know if I'm running over a little bit, but I'm nearly there. This is also in model hospital, and you can see the pressure ulcers that have been acquired in hospital by category. Now, in order to do this, the clinical coders need to have the words nosocomial or hospital acquired written in the clinical records next to that pressure ulcer. They can't make an assumption of acquisition because there wasn't a pressure ulcer for 10 days and then one appeared in the clinical records. They cannot make assumptions. So if it's written in the clinical records in a certain way, then they can capture it and you can see, as this organisation can, some really good information about the percentages that were acquired in your care. And that might be another data quality piece of work you need to think about doing. So in acute care, we're hoping that you will all adopt looking at this because we know that a lot of you have got some really good informatics systems in place that show you your pressure ulcer information. But a lot of you are feeding that in from your clinical incident reporting place. And actually, we've got 2 pieces of work going on here in 2 different places. And we should really all be striving to be getting it all in one place rather than duplicating the work that we're doing. So if you're starting to look at this, your initial piece of work might be around thinking about your standards of clinical recording and how accurately people are recording and have they got documentation that allows them to record it in the right place and documentation that means the coders can find it easily. Some of you that are on electronic systems will have tick boxes and little drop downs that you can use that can also say whether something's acquired in your care or not as well. So that allows the coders to code with Y95, which is the hospital acquired code. In the community, we are still trying to fully understand how the coded clinical entries in the clinical records relating to pressure ulcers, and we're also looking at leg ulcers, can then be extracted into CSDS and then popped into the model community health. We know we can see them in there. It's a bit like a brick wall. The way I think about this is you've got this brick wall and you're just looking at all these bricks and how do you find the brick that you need that's the pressure ulcer brick or the leg ulcer brick. And in order to get to that brick as well, all the other bricks needed to be there in place. And if one was missing, you can't get to the brick where the pressure ulcers are. So it's very, very complicated. And we're trying to understand that. And we're also doing some work with a couple of integrated care systems to look at a diagnostics exercise to help us understand about how to implement the recommendations. So going back to this where we saw earlier in the community care how the data flows through the clinical records, if you're thinking about quality improvement here, we'll start at this end. Then when the clinician's documenting the care, if you're using an EPR system, then you will need them to be doing that in a coded field. If they're just typing free text into the clinical records, that won't have any codes attached to it. Most of the systems don't anyway. So you need to give them templates and formats that allow them to for it to be automatically coded in the background. We're looking to standardize those codes nationally so that we know that everybody's using the same codes. And then we need to understand how those codes are popped into CSDS. And then hopefully we can then understand how we can get that into model community health. So we haven't got any goals on how long this will take us to do, but we're hoping that it won't be too long before we can start to see similar information in model community health with relation to pressure ulcers for community care. So a few references around some of the things that I've been talking about, and I think I've probably run over a little bit, so I do apologise about that. I get excited when I start talking data.
Many thanks,
Thank
Heidi.
you.
Yeah, your passion oozes out of the screen, and hopefully that has inspired many of the attendees today. You've certainly put it in a way that is very understandable, and hopefully will create that interest. I think historically, there's often been a disconnect, hasn't there, Heidi, between those who maybe historically have collected the data and those who have tried to make sense of it. And surely it should be also at grassroots, those people that are working alongside patients, trying to make sense of that data in terms of their own team. So how can you create this enthusiasm and interest at that point, really?
So I don't think you're going to do it for everybody, are you? There's going to be some
No.
people that it just doesn't interest them. But many of us are looking at this in the background. And what are we doing with it down at that grassroots level? Do we share it with them? Are we showing them what we're seeing? Are we making it personal to their area and the people that they're looking after? And I think it's about trying to do that somehow. When we were looking at our community hospital work, that's what we started to do. We'd just been grouping everybody in together, and we started to pull theirs out separately, start to show it them in a more interesting way. And now they're coming to us going, and our analyst teams going, can we look at it like this and can we look at it like that? So it takes a bit of time. Unless you've got somebody there that really loves data, it will take some time to stimulate that change. But I think it's about getting it personal to their area so they can see what their own individual problems are. Yeah.
And we've probably only got a couple of minutes, but if I haven't got a chance to go through them, I would urge you, Heidi, just to look at the comments in the chat. So, the people that
Yes.
really appreciated how you've presented this and how they're going to take this back to their own areas. But there's a comment here around underreporting.
Yes.
So for instance, if, category 1 and 2 are not reported, surely this makes it seem like there are no or low issues on the charts.
Yes, and I think what I would say about that is when we've looked at model hospital data, is actually those aren't missing in there. People are recording them in the clinical records and coders are coding it, and you're more likely to see those in there than you are in your clinical incident reporting system sometimes. So when you're looking at your data in model hospital, check it against what your normal percentages are. How many do you normally see as a percentage of category 2s? You might not know the category 1s if you weren't incident reporting those. So you are going to get category 1s in model hospital. But what we've found is a lot of the organisations that we've been working with for a couple of years now is that actually their percentages were sitting quite nicely with what they would have expected to see. So people are clinically recording these. We're probably just not clinically recording enough of them for it to be captured, or in the right way for it to be captured by the coders. Yeah. I'm just going to put my email address in, because if any organisations do want to understand model hospital in more detail, myself and or Jackie can come and talk to them about it. I'll just click that.
That's really helpful. Thank you.